Play fair, fair play.
Prendete la medicina prescritta.
El fútbol es el mejor deporte del mundo, entonces juega fútbol.
Respect girls and women.
Vaccinate yourself and your family.
Para conseguir controlar el balón, tienes que estar en forma, así que controla tu peso.
In life, use your head to protect yourself from HIV.
Fora de campo, faz os movimentos certos para evitar as drogas e o álcool.
Tómate la medicación prescrita.
Munissez-vous d'un moustiquaire traité.
Na vida, eu uso minha cabeça para me proteger das doenças sexualmente transmissíveis.
Como persona, quiero estar sano. Para tu condición y tu salud, toma una dieta equilibrada.
Wash your hands.
Controle seu corpo y beba agua limpia.
Fuera del campo, respetar a las niñas y a las mujeres.
No hay nada mejor que jugar limpio.
So we come to the last section after the Football from Health in Copenhagen. Now one of the practical programs, we will ask you also for active collaboration in the years to come. Now Astrid Junge will present you the first step, the implementation of the FIFA 11 for Health. Astrid?
Ladies and gentlemen, the FIFA 11 for Health program is a football-based health education program designed for children aged 11 to 12 years old. It's for boys and girls to increase awareness and physical activity. And it's designed to increase the level of physical activity and to improve awareness and knowledge of communicable and non-communicable diseases, with the overall aim to reduce risk factor and prevalence of these diseases. It has 11 health messages, which I assume you're all familiar with, starting with play football, respect girls and women, protect yourself from HIV and sexual transmitted diseases, avoid drugs, alcohol and tobacco, control your weight, wash your hands, drink clean water, eat a balanced diet, get vaccinated, take your prescribed medication, and fair play. Each of the message is supported by a well-known player, and it's presented in 11 sessions, each 90 minutes, divided in 45 minutes on the health message and 45 minutes on a football skill. The implementation starts with the teaching, and we have a very detailed coach manual which described all sessions in great detail. Teachers receive a 5-day course by 2 F-mark master instructors. The children are then instructed during school time by a mixed gender pair of teachers, and the schools receive equipment from FIFA. For the implementation strategy, 3 partners are important. It's FIFA, the National Member Association, and the National Ministries of Health, Education and Sport. FIFA supports the program in each country for 3 years. The first year is a pilot study where we educate 32 teachers, and we implement the program in 16 schools. Year 2 and 3 are cascade trainings, and after this, the national ministries should ensure the continuation of the program. By this, we can easily scale up for great numbers of teachers and children. The contribution of the 3 partners is FIFA provides the overall project management and evaluation, the financing and equipment for the first 3 years, and the knowledge and know-how of the program and of the implementation. The member association provides the facilities, the local organization, and the national project leader. The government ensures that the teacher have time to attend the training course and implement the program in schools and ensure the long-term implementation. For a typical implementation schedule is we start with an agreement between FIFA and the member association, followed by a pilot study where we want to make experience of whether the course will work in your country, followed by countrywide implementation to scale up for a greater number. The implementation in a little bit more detail. Year 1, we start with 2 FIFA master instructors instructing 32 teachers to become FIFA 11 for Health coaches. And in the first year, these teachers in pairs educate around 1,000 children. In year 2, again, we have 2 FIFA master instructors, and from the 32 teachers of the first year, we select the best 24, and these will then subsequently teach a great number, 288 teachers in the cascade training. And these teachers subsequently, again in pairs, educate about 20,000 children. Year 3, we have the national FIFA for Health instructors, and they teach in 2 subsequent weeks, 288 teachers each, which then can educate in the next year 40,000 children. You see, by this cascade training, it's very easy to reach great numbers of teachers and children. Of course, we need preparation. We need time for planning. We need to decide whether we want to implement the program in primary or secondary schools. We need to know about the school years and the school holidays, the number and duration of PE lessons. We need planning on equipment and budget. We have to take care whether the material needs to be translated in your local language, whether there are facilities for the training course, and what's about the local costs. We develop then a project protocol and an individual funding agreement for your MA, which is be signed by both the MA and FIFA. And then budget and equipment will be transferred. The key person in this process is your national project leader. He or she is the contact person for FMAC, the member association, and the local government. He or she is responsible for all local preparations and management of the program. So provision of all information which is required to design the project protocol and tailor-make it for your country, for the recruitment of schools and teachers together with the government, the logistics, which means the facility for the training courses, meals, customs, and all related. Arrangement of the equipment, as I said, it might be translation necessary. Sometimes we print locally, sometimes we shift it to the country. During the implementation, we do a very close monitoring and evaluation and would like to have feedback every second week about possible problems and the progress of implementation in your country. We have evaluation forms which are given to the children prior to the implementation of the course and after the end of the course to ensure and objectively measure the knowledge gain. And last not least, we of course need for closing of the project, the accounting of budget, and prepare the next step if the pilot study was successful. Up to now, we have implemented in 20 countries. And Dr. Colin Fuller will tell you about the results the program had in these countries.
So please welcome Colin Fuller on the stage. He's responsible for the implementation in the countries as the leading person, the head of the implementation. So Colin, let us know the results from those 20 countries.
Thank you very much, Jerzy. Thank you very much, Michelle. Thank you, Astrid, for the introduction to how the program is implemented. As we've seen from Astrid's presentation, the FIFA 11 for Health program addresses health issues associated with communicable diseases and non-communicable diseases. And this requires various approaches to how we implement that program. So the prevention approach which we've adopted in the 11 for Health program is focused on two strategies. Increase the level of physical activity by encouraging the children to play football and to learn football skills, and hopefully to generate a lifelong interest in playing football, even from starting at 11 years old, as Peter and Jens have shown you, right up to my age. One thing I will say about Peter's results, don't read everything into statistics because you can get any answer that you want. He demonstrated that playing football increases muscle mass. As you can see from me, it doesn't work for everybody. Does for some people, but there's always outliers. So we increase the level of physical activity through playing football, but we also are looking at increasing the level of knowledge about the health issues that are relevant to people in various countries through a process of education. But even where we're delivering an education program, this is very much based around physical activity. So no part of the program involves the children sitting in a school classroom, sitting at a desk, and becoming bored. They're doing something which they all enjoy, whether it's a boy or a girl. At 11 and 12 years old, there is very little difference in the ability of boys and girls and their interest in football. We find that at the start of the program, boys clearly prefer football to most other sports. Certainly by the end of the program, the girls' interest in sport has reached the same level as the boys. Now, in Peter Kristrup and Jens Bangsbo's presentation earlier today, they very clearly demonstrated the health benefits of increasing physical activity through playing football. And their results underpin this aspect of the program. And I have no intention of trying to expand on their excellent results. I think they speak for themselves. So I won't be adding anything to that aspect of the program. I will also not discuss results from the implementation strategies from the perspective of the individual countries, because Dr. Prince Pambo from Ghana and Jaising Mutaya from Myanmar will present their experiences from implementing the program in their own countries. So I'll leave them to talk about that aspect of the program and the results that they feel the program has achieved. I intend, therefore, to focus on the second strategy of the program, which is enhancing children's knowledge about health and using the approach that if you want to increase or change people's behavior, first of all, you have to get them to be able to change their attitudes to those issues, and the way in which you can do that is to enhance their level of knowledge. So I want to present some results showing the way in which the program increases the children's knowledge about a wide range of health issues. So first of all, to summarize the data that we collect, as Dr. Young mentioned in her presentation, we collect a lot of data during the program, particularly during the pilot stage of a program, to make sure that we understand all the issues in the country and have the opportunity to make any minor changes to the implementation strategy within the nationwide program. So I've listed on here some of the data which we collect during the program. We have a pre-implementation health knowledge questionnaire which is completed by the children. The children's attendance during the implementation is recorded by their teachers. We also collect progress reports after every 2 sessions, which is provided by the national project leader. That's one of the key responsibilities which they have for the program. And then we collect post-implementation health knowledge questionnaires from the children in order to monitor and measure the changes in knowledge about the specific health issues that we've included in the program. And then at the end of the program, the national project leader produces a final implementation report, which is sent through to me so that we get a good understanding of both the pilot stage implementation, the nationwide implementation, and it gives us the opportunity for continuous improvement in the way in which we implement the program, not only in those specific countries, but in future countries. The data which is sent through to me is then analyzed by myself, and a final implementation report is produced, which is then the results of that are sent back to the country and distributed within FMARC at FIFA. And also, most importantly, the results of many of the studies are written up and submitted to medical and education journals where they can be peer-reviewed by world experts in the field, so that we get not just our views on whether the implementation has been successful, but people who are not involved in the program, whether they feel that the program has been successful and whether the way in which we're implementing the program and analyzing the results meets all good scientific and medical practices. So you can see that there's a whole range of data which we collect. Now, there's a number of ways in which we can present the data to show whether the program has been successful, and we've presented some of the data using histograms previously to show changes in knowledge. But I want to present the data in a slightly different way to illustrate a different aspect of the program, to show how it performs through all the countries throughout the world. And the way in which I'm going to do that today is through the use of a radar plot. And as you can see on the outside of the radar plot, we have the titles of each of the Play Fair sessions, so from avoid drugs and alcohol and tobacco, control your weight, drink clean water, etc., through play football, protect yourself from HIV, and wash your hands. And at any stage, we can plot the value that we obtained in terms of the health knowledge on this radar plot, both from the pre-intervention health questionnaires and then through the post-intervention health questionnaires, and we can look at the changes which we've achieved there. So if we look at a very simplistic presentation, which is the equivalent of the use of histograms, on this radar plot, I've just very simply plotted the average change in knowledge across all health topics. So it's consistently 20% enhancement around for all the country results that we've reported on and all the health topics that we've looked at. So that's one way in which you can present the results, and that in itself shows that the program is very successful and enhances the children's knowledge. We can then look at it in a slightly different way, that we can look at the way in which knowledge has changed within each of the individual health topics. And you can see in these results that in particular issues related to hygiene, wash your hands, and drink clean water are particularly important. And in many countries, particularly in Africa, this is one of the major causes of early mortality through diseases related particularly to diarrhea. So you can see that we don't get the same enhancement for all health topics, but they average out at about 20% enhancement over all issues. So that's one way in which you can present the results, but it only tells you part of the picture about the success of the 11 for Health program. So I want to present the results in a slightly different way and look at the results across different continents. So you can see how the program is successful or unsuccessful, and I'll leave you to judge that when you've seen the results in different social, economic environments. So the problem of dealing with just absolute changes in health knowledge is that it doesn't take into account the baseline level of health knowledge in any of the particular health topics. So you may go to one country in Africa where malaria is a particular problem, and the children will have already been educated to a certain extent about the problems of malaria and the use of bed nets. So we might find that there's a small change and only a small enhancement in the children's knowledge about malaria, but that's because they already have a very high level of knowledge about the subject, and therefore there is not much area for improvement. In another area, you might have a very low level of knowledge, and you can get a high change in knowledge following the program. What we're particularly interested in is what's the final level of knowledge after they've entered the program for all health topics. The other point is that it doesn't also take into account problems associated with the language delivery, and I think I'm fairly sure that Jay Singh will mention some of the issues that we can encounter here. It doesn't look at the national education system, the underlying health problems in the country, national health provision in the country, in terms of do they have a high level of health provision, or is it a low level of health provision? Do they have a vaccination program? Are the children aware of a vaccination program? If they don't have one, their initial level of knowledge about that topic is likely to be low. If it's a nationwide program in the country, they will already be aware of the necessity to have immunization. And it doesn't take into account issues such as national geographical and logistical issues. And if you think about the fact that we've implemented the program in countries such as Mauritius, with a total population of 1 million, and we've implemented the program in Brazil with 200 million people. Brazil is the 6th largest country in the world in terms of both population and landmass, and clearly that has totally different geographical and logistical issues in terms of delivering the program compared to delivering the program in a small island such as Mauritius. So let's have a look at some of the results that we've got in the program in terms of Africa first, and we can look at the pre-intervention health knowledge. And this is for 8 countries, from Democratic Republic of Congo, Ghana, Madagascar, Malawi, Mauritius, Namibia, Tanzania, and Zambia. Mainly Southern Africa, but Western Africa represented there by Ghana. The important thing to note here is the wide range in the baseline level knowledge across different countries about different health topics. It's not always a low level of knowledge, it's certainly not a high level of knowledge, but you can clearly see that in some countries there's a very high initial level of knowledge about using treated bed nets in this country, and a much lower level of knowledge here. And similarly for protect yourself from HIV, high level of knowledge, low level of knowledge. So you're starting from different baseline knowledge levels. And just by taking absolute changes in health knowledge, it doesn't take that information into account. So if we look now at the post-intervention health knowledge, you see a quite different picture, because now you see a consistent high level of knowledge in all topics across all health topics. So wherever you start in the country, whether it's a high level or a low level, the program successfully brings people up to a very similar level of knowledge post-program. So it's very successful in terms of coping with different initial levels of knowledge in the children. If we look at Latin America, we've implemented the program in 3 countries in Latin America, 3 large countries, Brazil, Colombia, and Mexico. Here you see there's an apparent gap here against use of a treated bed net. That's because in these countries, malaria wasn't considered to be one of the major health issues, but we introduced control your weight here instead, where weight-related health issues was a much bigger problem than malaria-related issues. That's why there's a gap here. But again, you can see the wide variation in baseline levels of knowledge across different health topics, and also the wide variation within a health topic within apparently similar countries. You would expect similar levels of education, similar economic conditions in all of these 3 countries, but still quite different starting points. When we go to the results in post-intervention, apart from a slight anomaly on this one here for drink clean water, again, very consistent high level of knowledge transferred to the children post-intervention. So again, we've shown by going from taking the program from Africa to Latin America with very, very minor changes in the way the program was delivered, that we can implement the program very successfully and transfer high levels of health knowledge to the same age of children in different environments. Moving on to Asia, again, quite different culture, quite different social environment, quite different economic environment, and quite different education backgrounds. Also introducing issues such as language. Again, when we start from here, you can see we didn't use Control Your Weight session in this program, but we used the treated bed net. Again, in the 2 countries we've visited in Asia, Myanmar and Sri Lanka, quite wide variations in baseline knowledge in some areas. Similar knowledge levels in other, related to other health issues. Again, when we look at the post-intervention health knowledge, we bring the health knowledge of the children up to very, very similar levels in both countries, and quite different background of those children in those 2 countries. So if we look at those and try and reach some conclusions about that, we can first of all demonstrate that the FIFA 11 for Health program has been very effective in raising the children's health knowledge about communicable and non-communicable diseases across 4 different continents, and we've implemented in 19 countries. We've presented the program in 5 languages, from Burmese, English, French, Portuguese, and Spanish. I'd like to say I speak them all fluently, but I speak one of them reasonably well, one of them very badly, and the rest not at all. Although I do know 1 or 2 words in every language, such as pizza and pasta, which I learned from visiting these countries. That's fairly uniform in every country that we go to. So my language skills are expanding as I go through the program. The other thing which is important is that we've demonstrated that the program can be delivered in widely different social, economic, and health-related conditions with equal success in every country. We haven't yet been to a country where we've had totally different results from all the other countries that we've been to. The final level of knowledge which the children achieve at the end of the program is very consistent throughout for all health topics and across all countries. The important issue to think about in appreciating the success which the 11 for Health program is achieved is that we've implemented it in countries where life expectancy at birth ranges from 47 years to 77 years. That demonstrates an absolutely enormous range of health problems, health issues, delivery of health facilities within the country, economic resources which are available to deal with those health issues. We've delivered it in countries where the under 5 mortality rate varies by an order of magnitude from 14 to 111 deaths per 1,000 live births. Delivering in a country where 1 in 10 of the children that are born are likely to die before they're 5 is quite a scary statistic. But the program has worked successfully. As I mentioned earlier, we've delivered the program in countries with populations varying from 1 to 200 million, countries with geographic size from 2,000 square kilometers to 9 million square kilometers. Again, that demonstrates that the program can be adapted to wide ranges of population size, economic conditions, geographic size. And if we look at the economic resources which are available in the countries where we've delivered the program to, it ranges from $365 up to $11,000 per person. Again, that's an enormous range of countries, parameters within the countries. So if I can just summarize here at the end where we start from. This is all of the results which I've presented, and you can show the wide variation of starting points in all the countries that we've gone to across all of the health issues which are shown on this radar plot. But at the end of the program, the children in each of those countries all end up with a very similar level of health knowledge, which is, I think, something that I'm certainly very proud of, and I know that the other people that I work with within FMARC are very proud. And I think as member associations of FIFA, it's something that FIFA can be very proud of, that the 11 for Health is a very successful worldwide program. So I'll leave it there, and I will now pass it on to a very good friend of mine, Dr. Prince Pambo. Thank you.
Thank you. Prince Pambo is the national project leader in Ghana. He is a doctor. He is currently performing PhD in University of Saarbrücken, and he was very helpful in the campaign FIFA 11 against Ebola. I thank you very much for that immediate support and understanding in those countries. But today he will report us about the practical implementation in Ghana. Prince?
Thank you very much, Prof. And good afternoon to everybody here gathered. Quite a humbling experience to find myself here to report on 11 for Health in Ghana. And of course, quite an intimidating audience, knowing that 2 of my lecturers are in the crowd. But we'll try and we'll go through it. So Ghana, we all know it's one of the West African countries, and a country which I believe is a force to reckon with, debatably, when it comes to football. We have attempted to win most major trophies, yet to take the World Cup. So it's a country in Africa. Africa is made up of 54 countries, as we know, with some 1.2 billion people. And then we have about 46 million people participating in football, both recreational and professional. And Ghana is bordered by Ivory Coast, Togo, Burkina Faso. As a nation, it's made up of 10 regions politically, a population of 26 million people. And we have these footballers to be proud of, both the old and the new generation. We have Tony Bafo is down there, a very active member of FIFA. And Ghana had our own health challenges, which basically had to do with communicable diseases. So we had issues with malaria, we had issues with tuberculosis, HIV, AIDS. Until quite recently, non-communicable diseases used not to be one of our problems. So the very first time I heard about 11 for Health being discussed by Colin in Nottingham, straight away I knew that this was a program that Ghana needed so much. The doctor-patient ratio in Ghana is about 1 doctor to about 12,000 to 20,000, depending on which part of the country you found yourself. So obviously, this is a country which will want to invest a lot into preventive measures rather than wanting to treat, because you would definitely not have enough doctors to be able to care for the people. So we believed in empowering the people to be able to prevent. So I thought it was a program needed. So the talks started from there in 2011. Then fortunately, along the line, I think Mr. Anthony Bafo also had discussions with Professor Vorak, and 11 for Health started in Ghana. So the team from FIFA, led by Professor Vorak, visited Ghana in 2012. January had discussions with the various stakeholders. So the various ministries of education, health, youth and sports, the Ghana Football Association, the Professional Footballers Association of Ghana, which basically brought all the old footballers and the new ones together, met and had these discussions. So down there in that picture, we had the vice president of our association up there. I don't know if Prof remembers this particular photo. We visited one school which was already having their PE session, and the talks started. So the program kicked off in 2012, and it's been going on. We are in the third year so far. We've had about 15,000 people going through the program, almost 500 PE teachers involved. We've attempted going to all the regions in the country, though we still have quite a number of schools yet to be covered. The project has enjoyed a lot of support from the government of Ghana, from the Ghana Football Association. When FIFA sends the equipment, government gives us tax exemption to be able to get it out. It costs a lot of money to clear goods from Ghana, and I saw that to be a lot of support. The various PE teachers needed a lot of time off to be able to be part of the program. The federation gave us pitches for free, so we enjoyed a lot of support. And the media, I think on 2 occasions. First, when Prof was in Ghana, we had the opportunity to be on national TV to discuss the program. When Colin also visited the second time, we had the opportunity to be on TV. Members of the medical committee of Ghana Football Association had the opportunity to be on both TV and radio to talk about 11 for Health. And now in Ghana, when my phone rings, the first thing you hear is football for health. The first thing you hear is play football, play fair. I mean, it's quite common in our country now. And of course, football is a passion of Ghana, and whatever that gets associated with football has no option but to succeed. The teachers developed, presented the program with so much enthusiasm. They enjoyed it. The students enjoyed it. And it translated into an increase in school attendance, and various heads of schools could attest to that. So we could see it here. And we selected schools from both divides. I mean, so we could see from the pictures here that this particular school happened to be an elite one, and then the one to my left, probably not very elite. But when you looked at the messages that we were carrying across, then we thought that both schools would need it. You could see somebody with childhood obesity there in one of the pictures. This used not to be any problem for us as a country. And considering the number of pupils and teachers who were involved in the program, then we were convinced that it had reached so many people. Because average family in a country like mine, a household, I think one of the questionnaires I saw, they asked one of the people, how many people were in your household, and he mentioned 50. So if one child from a household where there are as many as 50 gets educated, then you can imagine how far the program had gone. Some of the benefits of the program, of course, physical education, at a point in time wasn't being recognized so much in our country. The schools did not even have pitches, but the introduction of football for health ensured that, we convinced them that you could do sports anywhere. And of course, the kits, the balls, the cones, the bibs, and all the things that FIFA brought gave some recognition to school sports. The heads of various facilities also confirmed this. We had an issue with, let me use the word disrespect for the girl child. So we even had a program in Ghana where you had to encourage girl child education. There were things that boys would be allowed to do and not girls. And I can't say here that that had changed drastically. Most of the heads of schools could attest to that. And of course, the program also brought various students or pupils closer to teachers. So it gave them the opportunity to be able to share things that were going on in their homes that ideally they could not talk about. Of course, some of these children saw what daddy did to mommy, if I should use the word, abusive families, and they had the opportunity to complain. And I'm happy to say that interventions have been put. I'm sure that when Colin and his team were putting together the concept of 11 for Health, they did not probably think that it could go this far, but I'm happy to announce that it had really, really traveled. Of course, we also had some very social benefits from this particular program, and notably, the first time I had to take some teachers to another city to implement the project, and they had to travel by air. I realized that it was only one teacher who had ever done that before. And for me and for them, it was quite a huge social benefit. And I did put here that one teacher walked up to me and then confessed that his marriage was going through certain challenges. I mean, almost falling apart. But that's 1 week that I gave him to travel out. And of course, I mean, he got something for an allowance. He came back a very different person. Of course, he didn't want to give me the details, what was pushing his marriage apart. But all he could tell me was that I had saved his marriage. I said, okay, then you probably look for the officials of FMAC and FIFA to thank them for putting your marriage together. Obviously, in nobody's wildest dream would you think that this program was going to do such a thing. It did it. So we were, as a country, we are quite happy. Children from abusive families had the opportunity to complain, as I mentioned earlier. And of course, some of us had the opportunity to make our specialty relevant, and also an opportunity to serve my country. Sports medicine is really not very developed in Ghana. So you find yourself leading such a project. Okay, so this is what it's all about. So we want to say we are very grateful as a country. I didn't want to go into the scientific benefits, but Colin had already mentioned them, the increase in knowledge, what the children now know that they didn't know, what they now think they can do, or what they do now that they couldn't do before. So going forward, the various stakeholders in our country have come together and decided that Football for Health should become part of school curriculum. So all pupils who will be going through first year of junior high school would have to necessarily take 11 for Health as a program and go through it. And because we already have teachers trained and then they already have equipments with them, they ensure that all the pupils who are passing through their classes now have this. And of course, we have a stronger interdepartmental collaboration. We have a regenerative health unit where we feed them with information. So whatever the teachers pick from their various schools, some of the schools are in the slums, then they are able to report back to the Ministry of Health, and then they put in various measures. And I think because we've been so successful, I would say, with the implementation of this project, we have formed a stronger platform where I believe we would be able to collaborate with any other international organization to cause a massive change in our nation. The various challenges we came across, of course, they were not challenges that we couldn't do anything about. We had issues with late arrival of equipment from FIFA and Adidas. So around that time, I think myself and Astrid will exchange emails, sometimes 4 or 5 in a day, because you have 2 days to a training program, and you still don't know where the equipments are going to come out from the airport. But then, in all that, we try to go. So we would only encourage that in the various countries where we are yet to start this program, we'll take steps to make sure that these equipments go early. Of course, difficulty clearing the equipment also. Ghana did not have so much challenge if only they came in early, but of course, speaking to other leaders in other countries in Africa, no, they had real challenges trying to clear some of these goods. Once it comes early, we did not have a problem. Normally, it would take about 3 to 4 weeks to get them out. Then difficulty in selecting instructors and various schools to be part of the program. I saw this as a positive challenge in the sense that every school wanted to be part of it just because the program was attractive. So I don't expect FMAC or FIFA to make it less attractive so that this challenge doesn't come up. But then probably would ask that we should involve much more schools. There are some heads of schools now who probably don't feel happy talking to me because I couldn't select their schools. Then some of the recommendations I would want to put across is that we should try. It would help if the project leader happens to be somebody who will bridge both health, education, sports, and then probably have a closer relationship with the federation. It takes care of a lot of challenges. I believe I was a bit successful with mine because I worked right within the ministries. I worked so closely with my federation, and everything was quite close to my office, so it was easy getting certain things going through. You would go through challenges if you don't get the right national projects leader, so it's an issue we want to consider. And then also regarding assistant project leaders, I think normally the program makes room for one assistant at any point in time. I would want to suggest that we'll probably get increase the number a bit more. I used more than 3 at a point in time. You needed so many people to be doing a lot of things for you. Of course, the various PE teachers and the coaches we used were so much helpful. And then, of course, the involvement of both central and local government from the onset. If the decisions are taken at just the central government, for instance, Accra is our capital city, and they hold the meetings there without involving the people down there, you get to the various districts and the regions, and it's quite foreign to them, and you normally have to go through several meetings. So my proposal would be that the very first meeting where leadership of FMAC visits the various countries, we should insist that both representatives from the regions and the districts would come and be part of these meetings, and once they know that, okay, this is what FIFA is bringing, because there are times when you get there because it's a FIFA project, sometimes the expectations are so high because they believe if a footballer is transferred for so much money, anything that has to do with FIFA, it's a lot of money, which I try to tell them it's not. So if they come in contact, with the various stakeholders from the word go, I believe we'll have a better program running. So on this note, we want to say thank you so much to FIFA and FMAC and all the individuals who made it a success, Astrid, Colin, Prof, and everybody who helped in one way or the other. I think at a point, the emails get a bit hot, and you needed to respond to them to ensure that the program goes on. Thank you so much for the attention.
Thank you, Prince. From the emotions, you understand why this program is so successful in Ghana. And now we jump over to the other continent, to Myanmar. This is a country which is very special. And Jae-Sing Mutia is one of the formal development officers of FIFA. And he took the position of national project leader in Myanmar. So we want to hear now your report. Thank you, Jae-Sing.
Thank you, Professor Jiri, for the invitation. Good evening, ladies and gentlemen. Mingalaba in Myanmar. We started FIFA 11 for Health in Myanmar in May 2012 in Naypyidaw, the administrative capital. It's the right place because this is where the base of all the ministries, all the government authorities were here, namely Ministries of Education, Ministry of Sports, and Ministry of Health. We organized quite elaborate opening and closing ceremonies the idea is to invite VIPs from the various ministries, as well as these will attract a lot of media attention. We had national TV, national newspapers covering the event to create awareness nationwide. Training courses, we had theories and practical. I want to thank the FIFA FMARC team. You can see Professor Giri and Astrid there in the theory classes, and then we also had practical session in the Youth Training Center Stadium. 1 year after the implementation in schools, 12 schools in Yangon, we had the graduation ceremony for these teachers in a Sky Star Hotel. Then, last year, in April, we went to the national project leader together with the assistants and the instructor. We were fortunate enough to go to Colombo, Sri Lanka, to learn from them during their refresher course what they were planning to do and how they are going to move to the next stage. So you can see here some of the Myanmar participants actively taking part in this program as well. When we came back, then the later part of the year, we organized 2 courses for 2 big cities. The biggest city is Yangon, and we had one in Mandalay for 24 teachers from 12 schools. Each school had 2 teachers. And then, like what Professor Colin pointed out, the key for us was also using the correct translators and interpreters, because the teachers need to understand. Although the second language is English, the command of English and the level of understanding is quite different in different schools. So the translators played a crucial role for us. The second pilot project was implemented in 2 cities. You can see the map. Upper Myanmar, Mandalay is here, and then Lower Myanmar, Yangon, or formerly known as Rangoon. So the teachers did a good job in implementing. And in this slide, you can see the 11 weeks program started in November and finished in February. During the implementation, we had a lot of monitoring and inspection visits to give feedback to the teachers and also to ensure that quality delivery of the sessions in the school. Even the president, he was one of the key people for us, a dynamic leader, President Wu Zhao Zhao. He also visited 2 schools when he came to Mandalay for a Champions League match. So these are the results comparatively to 2013, the one in red, and the one in blue, which has got a better, more significant improvement for the second pilot phase. What are the reasons? These are the success factors for us. We had excellent cooperation from FIFA, FMARC, Development Office in Kuala Lumpur, AFC, and Myanmar Football Federation. Good collaboration between MFF, Ministries of Education, Health, and Sports. Then the unique thing here, sharing of experiences. This is a key for us because we learned a lot when we were in Sri Lanka, not just from Sri Lanka Football Federation, because Myanmar was the first country to implement this project in Asia, but because from the FMARC team who were there. So we had a lot of discussions and sharing of experience during this time. In return, we also invited Cambodia and Thailand. When we did our courses in Myanmar, Cambodia was present, Dr. Paisan. Unfortunately for Thailand, it was national holidays and there were some difficulties in getting the visa. Maybe we'll do it the next time around. Regular monitoring and reviews by national project leader and assistants. Appointment of the right person for the right job. To coordinate this program is not easy in Myanmar. You have to collaborate with a lot of people, teachers, district education office, and so on. So you have to get good people who are able to work independently in some times and with minimum supervision and able to make the right decision. I already explained about local translators and interpreters. And we had excellent program assistance from FMARC, you will see in the next slide. And strong support from the MA's top management. The MFF president himself personally takes it upon himself to ensure that we do quality. When I said the protocol paper in FIFA says we have to print 200 posters, he said, no, we make it 500 or 1,000. I want to go give more to the schools. Let them spread the news. So he puts the money where his mouth is. The program is very flexible and adaptable. For example, we had translation and back translation, and we used two doctors who work in football in Myanmar to ensure that it is correctly done. And then we could be flexible in taking out some of the areas in, say, session 4 on avoiding drugs. We have problem with some people having to eat these bitter leaves, chewing this areca nut with limestone paste, and the mouth turns red, and they will be spitting everywhere. Sometimes you stop at traffic lights, they open the car door, they're spitting out, and it's also causing a lot of oral cancer, throat, mouth, and stomach cancer as well. Then one session on the AIDS we did not use because we used controlling your weight more, emphasis. Like Prof. Jiri predicted in 2012 October, he said fizzy drinks and fast food will come very fast into Myanmar. It is already there, going out very strongly. And why we didn't use AIDS education here? Because we already have another program. As CEO of the Myanmar National League, we have a collaboration with the UN AIDS. And we have with them a program to go and teach this program. So we did not want to use it again. Challenges, like I said, the monitoring is key here for quality delivery sessions in school. And to have one assistant, I'll agree with my colleague, Prince, because to have one assistant sometimes is not easy. We have to use more because in Yangon, 12 schools, in Mandalay, 12 schools. And then now we have increasing costs. After the third year, then we are going to go on our own. And in some developing nations, maybe we might not get as much support financially as we want from the government ministries or authorities. A very tight timetable and many other school activities. So there are a lot of changes to the program. So recommendation, appointment of right people, coordinators from ministries of education as well. We were lucky to have Prof. Jiri himself and Dr. Guru to meet with the ministers, and that helped us to break the ice and carry on with our work. Maybe in future we also have to look into some marketing partners or sponsors. Already in Myanmar there is interest from some car makers from Japan, like Toyota, Mitsubishi. They are very interested in this program, but we do not want to contravene or, we need to collaborate well with FIFA marketing as well to see what is suitable before we decide anything. And maybe the course we can start it earlier. Like I said, the school timetable is really congested. Next step is cascade training. Prof. Colin is eagerly looking forward to come with his team. And we will have 144 schools in Yangon and 144 schools in Mandalay to be trained. And the teachers will be there from the schools as well. That is on Myanmar. Now for the second country, on Sri Lanka. Sri Lanka is an island with about estimated 22 million population. And you can see in the screen the various health risk factors that they have. And these factors were rightly addressed in the FIFA 11 for Health program in Sri Lanka. So here you see the crucial picture of the various people involved in the Sri Lanka Parliament complex. So football brings you to the highest level for these meetings with FIFA as well as Football Federation Sri Lanka and FMAC together. And Professor Dr. Estrid, she was one who conducted this course there. And their aim is to reach every school in the country by 2015, 2016, and they are on the right way towards this direction. The refresher course was held for the teachers who conducted the pilot project, and they were trained to be train the trainers for the next session. Refresher training course conducted by the FIFA instructors in the FIFA Build Goal project, Football Federation Sri Lanka's house. And you can see in the far end there, Professor Colin walking around under his watchful eyes. Everywhere he is listening to whatever that is taking place, whether it's in the field or in the classroom. So these teachers, they were trained as instructors, and now they are delivering to approximately 300 teachers. In Kalutara, this is a teachers training college where they carried out this 1 week after their training. Success factor is very close to what we have experienced in Myanmar. Good cooperation between the Football Federation, FIFA, AFC, and also partnership between Football Federation and the government authorities there. The right person was appointed as national coordinator. Anura De Silva. Today, this Saturday, last weekend, he has been elected, appointed as President of Football Federation Sri Lanka. So for those of you aspiring to be in football administration, think about FIFA 11 for Health. And as usual, very good cooperation and guidance from FMARC. And when we were there together with Anura, he said how much Professor Giri and also Dr. Colin and Dr. Astrid helped them. And the top management from Football Federation Sri Lanka, the president himself, gave good support. Okay, with that, I end my presentation. Thank you.
Thank you, Jay Singh, for this convincing report from the countries in Asia. So I will conclude with the 11 for health to prevent diseases and how we go around. So our intention is, in the time between 2015 to 2019, to implement the program in approximately 100 countries. It is very ambitious. We can only do it as a team with your support. And again, the doctors, they should and they will play the key role in the implementation. We have started to cluster the countries because particularly in small countries, we cannot visit one after the other. So last month, we visited the Caribbean region with 7 countries, with Colin and Astrid, just to give the potential national project leaders and the representative of governments the insight to start the pilot. So the first courses will be organized this summer in Caribbean region. Cambodia has been already mentioned, as well as Thailand. So know-how transfer from country to country. Myanmar transfer know-how to Cambodia, Cambodia transfer to Thailand, and so on. So we want to have this snowball principle. Now, originally it was developed as a legacy for Africa, Latin America, but now a big intention came from Europe. And obviously, the big guys from Copenhagen, they understand the power of football. So they convinced, and last week we met the governmental representatives in Denmark, and the president of the Danish Football Association mentioned very clearly, I want to have this program within 2 years in every school, from Greenland all the way to the south. And we start in north, in Greenland, and we go one region after the other. There are 98 regions in Denmark, and he wants to have it. So the commitment comes from the Football Association. Now, the Danish group, together with Colin Fuller, is adapting the program to the new social, economical environment. I don't want to differentiate between developing, non-developing, between Western and Eastern, and rich and poor countries. There are different social, economical environments, but the same problems with the health, in particular when it comes to the non-communicable diseases. We had the privilege since 2005 at the Congress in Bahamas to present the idea to the FIFA Congress. And at the Congress 2013 in Mauritius, there was official voting. Does the FIFA Congress support the program 11 for Health? And you will not believe, this is extremely seldom, but there was 100% yes. Sometimes there are some no's, or because people are maybe not present. They were 100% supporting the program, and it was reinforced at the last Congress 2014 in Sao Paulo. So we have the support of the member association. We are interested in the multiplication, but most important, the quality. We need to audit and monitor on the effectiveness in the different parts of the world, as has been shown by Colin Fuller. Sustainability is the key. Usually at the beginning, there is a big emotions and big fire, but we want to keep it that way going, as was presented by Prince Bamboo in Ghana and Jaising. So the strategy should be designed for at least 10 years to reach the entire population. Colombian government has decided to include the program as a mandatory part of the public health policy for 10 years. So whether it is the same government or the government changes at the next elections, the program will continue. And this is the way how we want to go in the future. The success is through partnership. That has been mentioned very impressively by the national project leaders in Africa and Asia. Ministry of Education, Health and Sport, the member association, FIFA, and if possible, independent monitoring institution, a university. So what are the next steps? You can express the interest and contact medical office, medical@fifa.org. Discuss within the member association management. You doctors discuss with the member association management. You contact us. We have created a full position with Claudia Grasser. I will present her and introduce to you tomorrow. Then you contact the government, the Ministry of Education, Health and Sport. We will provide you with the complete information package so the government can study in advance. And you organize the meeting with us, with FMARC, with the member association and the government. And then Astrid Junge will prepare jointly with you the project proposal for your country, with Colin Fuller jointly the budget and so on. And I just mentioned time needed between you express the interest and we can start with the pilot is somewhere between 3 to 6 months. Of course, we cannot cope with 100 countries at the same moment, so we will organize it for ourselves also for the future. So this is the way what we are planning. We have the support of FIFA president. We have the support or even mandate of the FIFA Congress. Now it's up to us to fulfill and complete the expectation. And for this, we need you. So with this, we closed this session, FIFA 11 for Health. And I would say we allow maybe 5 minutes discussion. So I ask Colin, Astrid, Prince and Jason come to the stage. And we can maybe tackle a few questions. Please, do not leave the audience. At the end, after the discussion, we want to use this unique opportunity to have representative of 198 countries, the doctors, to make a group picture. We have a star photographer from the Getty Images. I would say that he's coming closer to the Cartier-Bresson or René Burri in Switzerland, and he will take the group picture with all of us on the stage. So please don't leave the room. Now the floor is open for discussion. Please be ready with the microphones.
Yeah. Thanks, Prof. Comfort Chonge from the Kingdom of Swaziland. Especially my question comes to you, the steps in applying for this program. you find that the member association, they really embrace this, they like it, they want it. But when you request that, can we have this program? They will say that they've requested more causes from FIFA. So the quota is full. I don't know how true it is that, because the way you put it is like, I can conduct the medical office within FIFA, and I do the course. Because not that they don't want it, they want it.
Well, thank you for that. We were waiting to have the complete support. Now the FIFA administration approved the budget. We have the money approved for 2015 till 2019. So now we have created the infrastructure and the logistic within FIFA that we can go ahead. So show your interest, and then we will come to Swaziland. Yes.
Merci, Professor.
Thank you, Professor Dr. Gubo from FDC. We've also taken part in this project in the Democratic Republic of Congo as well. And we wish to support the recommendations from Dr. Guest. This problem is an extremely serious one, the customs problem, for the material, the equipment. As for the assistance to the national director, it's very, very difficult to work this way. If you have 2 or 3 assistants, you might be lucky. It might be instructors that aren't able to fulfill their tasks. In an organization such as mine, we have 12 million inhabitants. We have transportation problems to get to the schools. If you're on your own and you're not involved, and you're waiting for a competition of the organization, you have to get involved yourself, and you need your 2 to 3 assistants to rely on. Thirdly, government changes, and we knew that the Vice Minister, Minister of Education would support us. The others, they're fine for the graduation ceremonies, but apart from that, in practical terms, not really. So really we're talking about the leaders that we need. If we don't believe, we need passion. We need people who are committed. Otherwise, the government won't go very far. Fourthly, we also have the issue with enthusiasm in schools. We have really interesting projects. Lots of children come along, they look at the others doing their work, and they say, no, we can't do that. There are teachers who've been chosen by FIFA, and children who see the others who have been chosen. If you've got a school where there are 600 children and perhaps only 30 can take part in the program, so there's a lot of jealousy, a lot of envy. And if we could go a bit faster on those projects, that would be good. Another phenomenon I've seen are the pastors in the churches. When children tell them about the success of the project, they want these things to be done in churches as well. Is there no way that we can use both schools and churches, where at least there are structures we could draw on so that we could spread the message? That's my contribution.
Merci beaucoup for these comments. The points are well taken, and Astrid and Colin are registering. Yes?
Merci, Monsieur le Président.
Thank you, President. I closely followed all those presentations. Really, there are some very interesting projects, and I hope this is also a creed for fighting some scourges which also affect the health of our young people, notably drug addiction. We've talked about malaria, we've talked about preventing AIDS, alcoholism, and so forth, but there is drug addiction, and that's also a scourge which has harmful effects on the health of children and young people. And it would be a very good idea to include this point on the program for prevention. It has a devastating effect on our young people, especially in countries, developing countries, and even more developed countries. Secondly, I have a question which strikes me here. that I'd like to put to the people who are primarily responsible for FMARC, and that's this figure 11. We often hear 11 ways, 11 for presenting doping, 11 ways of encouraging healthy. Why this 11 all the time? Could you explain that to me? Thank you.
I can't believe that question. Yeah.
Okay, more questions? Yes.
I'm from Suriname. My name is Krishnadat, Dr. Krishnadat, and I would like to ask two questions. First, it was brought forward that small countries should apply in groups. Is that a fact, or can we also apply separately? Because Suriname, as a Caribbean country and the South American country, we also always have a very difficult position. Also, we are Dutch-speaking, so we do not fit into everything as possible. So I wonder if we could still apply as a separate nation. And further, I was wondering also if there are also measurements done on the translation from the knowledge to behavior of the children. If already focus has been put on that, because finally we want to have behavioral change, not only knowledge. And an interesting fact that was mentioned by Mr. Prince is that the knowledge that the children bring home, it's also spread through their families and so on. And I wonder if there are also measurements done on that, because that would be also very interesting. Thank you.
Colin, can you answer? Colin, can you answer briefly?
As far as the Dutch language is concerned, this year in August, we're running a course where the first representative speaking Dutch will be attending from Curaçao. So Dutch is definitely on the horizon, the close horizon. And the aim is that the people we're teaching from Curaçao will act as cascade trainers for the other Dutch-speaking islands in the Caribbean. At the moment, we don't have any instructors that speak Dutch, which is why we're taking some from Curaçao, because they're happy to go for training in Puerto Rico, where the course will be delivered in Spanish. But they will then act as cascade trainers in other Dutch-speaking countries on our behalf.
Okay, next question in the back.
Yes, Gotuso from Peru. Today we received a lot of very interesting information, very outstanding information from different lectures and presentations. My request is easy to have all these slides, all this information with us, or you will send, or we need to go to YouTube? Maybe it's important to have all these slides from your presentation, from all the presentation. Will be very useful for our work.
All the presentation will be downloaded on the YouTube, so you can see them, and it will be accessible for all of you. Give us a few days. Actually, the entire conference is live streamed today, so it was already distributed, and it will be made available later on in a few days. So if there are no more questions, we leave it after this very long day. I invite you to the stage. Alexander, it's up to you to create the group here.
One more question.
Please come to the stage. So we can start here in front. Several rounds.
He's always good for a camera. I have no problem to say it. That's good.
Oh, ja, gut. Hoppala, hoppala, hoppala. Ja, ist nicht von mir. Sorry, it's not my one. All on the stage. Mein lieber Mann. So, ladies and gentlemen, without any mobile phones, everybody comes on the picture. It's a huge it's a huge landscape, but it's okay.
It's unique opportunity.
It would be nice if the people on the outside, left and right, come a little bit closer, a little bit more squeezing. I know it's a challenge, but maybe we can try it. If it's possible, we can have more people here in front. We can have more people here. If someone was going down, it's fantastic. Hirschi, did we have any equipment that we want to show here, or whatever typical ones? Where, or a banner? Did we have a banner handy quickly or not? Anything?